I would like to welcome you to Detroit and introduce Dr. Terry Jaklin from Waterdown in Ontario, Dr. Joseph Hewett from Los Angeles in California, and my name is Mark Haacke, and we're here today to talk a little bit about the current status of CCSVI and multiple sclerosis. And Terry, perhaps you could give us an overview of your background and your interest in this area.
Sure. Well, first of all, I'm a patient. I was diagnosed with multiple sclerosis almost 26 years ago, and I've just sought treatment for CCSVI, so that's an experience that I'm thrilled with, and I'll share a bit more about it. And I'm also a naturopathic doctor, so I have the experience of seeing many patients who make the decision to have CCSVI or not. My own experience was wonderful. I went down with some skepticism only because I've been diagnosed for so long, and was delighted to find a number of improvements that have really changed the quality of my life. So, nice surprise. Some immediate things that you hear frequently, an improvement in temperature, an improvement in bladder, an improvement in energy, and then certainly my core balance is the big win for me there, because I feel like I can learn how to walk all over again. So. And you do this for a living.
Yes.
Which is a wonderful thing.
My name is Dr. Joseph Hewett. I'm a physician. I'm an interventional radiologist. One of the founding partners of Synergy Health Concepts and Pacific Interventional in Costa Mesa, California. We practice exclusively in Costa Mesa. We've been treating people with venous abnormalities for a very long time. 15 years. Our practice has been established for 3 years, but we've been treating these venous abnormalities for a very long time. When we became aware of the concept of CCSVI, we really felt we could lend a great deal of knowledge and experience to the treatment of the problem, and that's really how we got involved.
Excellent. How many people have you done?
We treated somewhere between 500 and 600, I believe.
So my interest, I'm Mark Haacke, and I'm a physicist at Wayne State University here in Detroit, and also with the MRI Institute here in Detroit. And my interest also goes back about 15 years in studying the veins. We tried to develop some technology we call susceptibility weighted imaging that lets us look at the veins and also iron in the brain as well. And a number of years ago we began to look at multiple sclerosis as one of those diseases where perhaps there was a venous problem associated with it, as early literature had suggested, and also in the last few years to study the iron content. And what we found was that there seems to be a significant number of MS patients that show abnormal iron content compared to normal people. There also is a change in the small venous structure in the brain, and actually that's been demonstrated by some other researchers in New York, showing that the more progressive you get, the less visible those veins become. So from our perspective, we felt for many years that the vasculature may be playing a key role in multiple sclerosis, and that's basically how I got interested in this. And I'm interested in what you have both said, in the sense that now that there have been thousands of people who have been treated using angioplasty, one of the critical issues, I think, is that we're able to do appropriate research with this, that we can follow the patients over time, that we can look at what their status was at the beginning, so that they may have an ultrasound scan or a CT scan or an MR scan prior to their treatment, that they get treatment, and then that we can follow these people and find out, has their blood flow returned to normal? Are the lesions going away? Is the iron content going away? Or if patients do unfortunately have problems with restenosis or other difficulties such as thrombosis, they may need to be imaged again, and then we can monitor this because we'll have the baseline scans that were associated with this. So I think that this is a wonderful marriage between the needs of the patient and the treatment process and the imaging and research process that can all go together here.
That's right. And the imaging, or the research process, is so important to make this real, so to speak, right? to get this in the textbooks as a legitimate concept in the world of multiple sclerosis?
Well, you raise an important point, because we're so early in this game at the moment that we haven't done double-blinded studies yet. We've really seen the world do an observational study that shows that there is some credence to this theory by Professor Zamboni that there is cerebral, spinal, venous insufficiency. And I think to demonstrate this from a pure research point of view is going to take very well-controlled studies. It's going to take animal studies. It's going to take the physics and mathematics of how the whole vascular system in the head and neck and spine work, and how all these things integrate together to create this immunological response, this inflammatory response. We don't know if the vascular problem is the cause, but there certainly appears to be a strong association with this. So it opens up completely new doors of study that we hope will help better understand multiple sclerosis.
A couple of points that you make there, and I don't know where to begin with them, but first of all, you said it's important to have the science. Does that mean people should stop getting the treatment now and wait for the science, or continue to do it and wait for the science to happen?
Well, I would pass that question off to Dr. Hewett at the moment, because I'm a physicist, I'm not a physician, and perhaps he can speak more to that.
It's a difficult question to answer. As a physician and a scientist, we always like to have very strong scientific proof before we go treating people in some manner. I think this poses a very difficult problem for MS patients, the MS community, and physicians in general, because we do see such a strong association, and I'll use that word, association, between the treatment and improvement of symptoms in patients. I think with any new or novel treatment that can affect people and patients in a very positive manner, we have to give some credence to some of the empiricism of the good results that we're seeing. And in our practice, we see a large number of patients showing good results from the treatment. And I know that we do a very good job, and we can treat patients safely and effectively with a practice, venous angioplasty, that has been around for as long as angioplasty has existed. It's a very safe procedure. And in this manner, I would like to think that we could administer this treatment to patients who request it in a safe manner, rather than necessarily waiting for the procedure to show a direct causality and causation between doing exactly this and seeing this exact result. If we know we can benefit the patient and do it in a safe manner without compromising our ethics and our morals, I think we should do it.
So running them both in parallel then, the clinical and the science.
Absolutely. At the same time that we're treating patients and we're doing everything within our knowledge to help them and improve their quality of life, I think it's tantamount that we're also engaging in efforts such as Dr. Haacke's doing, and we are doing with Dr. Haacke, to try and lend some scientific proof, some causality and some causation between what we're doing and the results we're seeing, and perhaps try and focus down what we're doing instead of perhaps a shotgun effect, doing a lot of different things and finding some results and not knowing what the direct correlations are, to being able to say, when we do this, we can usually say we're going to get that.
Right. And in defining this and that, are there certain things that patients should be looking for when they go out to make a decision about where they would like to have that done?
If I were to send my mother or my brother or a family member, I would tell them first to talk to the practitioners about not just how many CCSVI cases they've done, but how many venous interventions they've done, how long they've been practicing venous intervention. It's really not that complicated to put a balloon inside somebody's vein and increase the pressure and watch it go up.
Right.
I could teach my young 10-year-old nephew to do this, quite frankly. It's not that complicated. It's the extremes and the far ends of the knowledge base that you really want to make sure that your people have. The ability to get through very tight areas of stenosis, to deal with those problems, the ability to know what to look for. we like to say in medicine that you don't know what you haven't learned. So if I don't know to look for something, I can't tell that it's, there's something wrong with it. You want to make sure that the people who are doing these procedures have the knowledge that they're treating the valves. In our practice, we found that it's of tantamount importance to be able to perform valvuloplasty, in a sense, to disrupt the valve at the base of the jugular veins and at the apex of the azygos vein in order to achieve a durable result where the rate of restenosis is decreased as much as possible. I would encourage people to make sure that the physician is performing the procedure is using adequate size balloons. Small balloon angioplasty in large jugular veins is not going to have a durable result. I would encourage people to make sure that all the physicians are looking at the azygos vein. We're finding more and more azygos abnormalities. Even on venograms that show the azygos looks normal, we will often put a balloon inside of it and blow it up and see an abnormality.
Once you've already blown it up.
Once we've blown the balloon up, we see a waste on the balloon indicating that there is an abnormality that wasn't apparent. So we see a lot of patients that come to us and say, I had a venogram and I was told my azygos vein is normal.
Yeah.
But when we blow a balloon up inside of it, we see that it wasn't necessarily normal. Okay? I would also say that you have to make sure the inflow and the outflow of all of your pipes, so to speak, are working. If I have a pipe and I open up a narrowing at the bottom of the pipe and there's still a narrowing at the top of the pipe, I haven't done necessarily that much good. So if the top of the jugular vein shows a narrowing, that has to be addressed as well in addition to the bottom. And if that means approaching the top of the jugular vein in a very esoteric fashion, it's important to have a practitioner who has the skills to be able to treat the difficult stenoses, not the easy ones.
Now, perhaps I can ask you a question here and at the same time make some comments about the different types of imaging that are involved.
Yes.
Sometimes people can have very complicated vasculature, especially the venous system. Dr. Zamboni, if I recall correctly, he found a lot of problems in the azygos also. He used ultrasound in order to study the dynamics, so he would look at the flow with the ultrasound, he would look at stenosis with ultrasound, and he could do that real time, which is a very big advantage. So he could watch the flow throughout every heartbeat and pick up that information. And so even though there may be some difficulties with having to put pressure on the neck and questions that arise about compression of the jugular, those people who are skilled with that, they know how to deal with this issue. But ultrasound also has trouble penetrating deeply, and it does a good job for the surface. There are special ultrasound units called transcranial ultrasound that can actually probe vessels in the brain, and it's work he did in the straight sinus, for example. From my perspective, we're interested in more of the three-dimensional nature of MR angiography. That gives us the ability to look at all the arteries and the veins in your head, your neck, and the aortic arch, and also in the spine. And with that three-dimensional information, we feel that could be a very good treatment planning procedure for the interventionalist. And also, again, remember, it stands for, it's kind of the control for the patient before they've been treated. We can then look at the blood flow at a variety of locations in the neck, and right now we're looking at 3 different locations in the neck. One in the lower level by the confluence of the jugular with the subclavian, and then we go all the way up to C1, C2. We can measure the blood flow in every major vessel in the neck, and so this gives us cardiovascular input-output associated with this. So that's a big advantage if the patient is going to then have a scan sometimes later in the future where, from the neurologist's perspective, he or she will get all of the conventional scanning, so the neurologist will have the information they need pre and post, which will also be important from a research perspective. But we'll also be able to quantify that blood flow before and after treatment. So we can, rather than the patient saying, well, I feel better, we can give this a real objective determination that the blood flow has changed from 12 milliliters per second to maybe 13 or 14 milliliters per second, or whatever it does change to. And so all this information becomes part and parcel of the care of the patient. And so I just wondered if, Joseph, you might speak a little bit from your perspective to the needs of imaging, and of course angiography is another form of imaging. How do these complement each other?
Well, I think I would first of all start by, in my mind, there's sort of three sets of imaging, as you discussed, Mark. There's Doppler, there's MRI, and there's the angiography. And of course, the angiography has classically been considered the gold standard, which is a term we use in medicine to denote the thing that gives us the best answers the most often. And I would still say that, but I think that these other imaging modalities are very important in the overall treatment and care of patients with CCSVI. And I think this idea of marrying the two really improves the overall treatment. Doppler, I think, is a useful tool. It's a good screening tool. It allows me to take an inexpensive instrument and perform a relatively inexpensive exam, an easy exam, to get a broad idea whether or not you fall into a normal or abnormal category. I think it is also a useful tool in the sense that it allows us to look at a very good dynamic picture of your veins. Having said that, I prefer the MRI. And I think it's important for patients' sake to make a distinction between the normal MRIs that MS patients normally get and the MRI that Dr. Haacke performs.
Right.
The normal MRI that most patients get for MS is looking at the plaques in the brain.
Right.
Pretty simply, right?
Mm-hmm.
When I talk to patients about the MRI that Dr. Haacke performs, it's much more detailed MRI, okay? And it's very useful to us as a practice. First of all, it's giving us flow data of these veins, all right? And this can often be useful. Rarely, this flow, I would actually say occasionally, this flow data is going to point us in the direction of narrowings or stenoses that may not have been completely obvious on the venogram, okay? And really what that lends itself to is a more thorough and complete treatment. Because as a practitioner, we look at this and we can say, well, look, this is abnormal, so we have to make sure we go and look in this area when we do the venogram, or pay more attention to it. Or we see flow abnormality at the valve, and so even if the venogram sort of looks plus minus, I'm going to make sure I blow up a really nice big balloon to make sure that that valve is completely treated. It's more information, and more information in this case is a good thing.
Right.
It is also useful in that it provides us with a very good MRV, a map, so to speak, a road map of these veins. And this road map is just as if you were going to drive from one side of Detroit to the other. You'd rather have a road map. You'd get there easier, more safely, more effectively.
I would definitely like a road map.
Occasionally, it'll change how we treat the patient. A good example of that is the azygos vein. The azygos vein can have a variety of different anatomic configurations, and it may change how we approach our treatment to the azygos vein. A typical approach for treating CCSVI patients is through the groin. The azygos vein, by way of example, may have an anatomic configuration that may encourage us to go through the arm instead. It may make the approach to that vessel easier. And without the MRI, we may or may not have known to do that. And I also think that the iron quantification that the MRI provides is, it's going to be a good surrogate marker in some manner in the future for, who knows, treatment success, medication, staging of the disease. It's a good and useful tool. And I think that, in sort of an altruistic sense, we talked about doing the research while we're doing the treatment. If we're going to be doing this and undertaking this task with any degree of seriousness, we have to be, whenever we have a chance to apply science and extract information from what we're doing, I think we're obligated to do that. And the ultrasound, while it does provide some information, I think the MRI provides much more information that we're going to be able to take in the future and create those lines of causality and those lines of causation between treatment and outcome, and find out what works and what doesn't, right? Mm-hmm. I think the other advantage of the MRI, quite frankly, is it significantly decreases the degree of inter-operator variability. Ultrasound is like knowledge. A little knowledge can be a dangerous thing, right? I can put an ultrasound in your hand, and with a well-trained technician, we can get a good study. With a poorly trained technician, that study may not be quite as useful. And those CCSVI criteria that we all like to talk about may come into question. We do see, I don't want to say often, but we occasionally see people who will have 1 or 2 CCSVI criteria by ultrasound. Then when we do the MRI, there's gross abnormalities. Okay? Doesn't happen all the time, but it does happen. So I guess what I would say in summary is that I think the imaging, of course, is very, very useful, not just from a treatment perspective, but also from the other half of what we're trying to do is establish the science and the causality and the relationship behind what we're seeing and what we think is abnormal and the treatment we're doing to try and improve the lives of the MS patients.
And I suppose that imaging will also come in handy in the case of restenosis or situations down the road, because we don't know a whole lot about restenosis yet, and maybe either of you could speak to restenosis.
Perhaps I can comment on the imaging first,
Sure,
and then pass it back. Before I forget, I did want to mention that it would be nice if we can integrate a lot of these imaging tools together to get a more complete picture. And perhaps later you can speak to the role of IVUS, or intravascular ultrasound. But you know, to really answer one of the critical questions is why are some people benefiting from this treatment and you know, fairly well, and others aren't benefiting as well. In order to really study that, I think what we're finding is that there are tremendous variants. Although the valves may be playing one of the most important roles, there are such anatomical variations that we can see the truncular venous malformations, which are basically, you get a jugular stump that often only has a tiny little string feeding up to the rest of the jugular. Well, luckily, if that's the case, you can still get in with the catheter and balloon that. We see cases where some people have beautiful engorgement of the vertebral plexus, which has then served as collaterals for allowing the blood to get out of the brain correctly. But there are some people who don't seem to be able to get that development. And so in terms of looking at all the variables, from our perspective at the moment, there appear to be dozens of variables associated with this. And in order for us to draw conclusions as to why one person who has perhaps almost the same truncular venous malformation benefits far better from the operation than someone else, we're going to have to study the entire vasculature of the system in order to do it. We're going to have to understand these dozens of variables. And that's going to take time and probably a study of hundreds, if not thousands, of MS patients before we can get to that point. And I think that's a critical role at the moment that the imaging is going to play, because you may have treated them and they may recover, they may not recover. So our hope is that imaging will be a means by which we can really help understand, maybe even eventually predict, who will recover from this sort of thing. So Joseph, maybe you could add a bit more to that and about the IVUS idea as well.
Well, maybe I'll start with the IVUS. IVUS is intravascular ultrasound.
Okay.
It's basically, it's like a catheter we put inside of a vein or artery, and it gives us pictures from the inside. The nice thing about IVUS is that it gives us real-time visualization of valves, for instance, moving structures, very intimate details of the vessels and the stenoses. We can also use flow measurements and pressure measurements at the same time or in conjunction with these IVUS pictures and get really detailed in vivo or in the body data. I think this will be very useful, and you know, down in California where we practice, we're starting to do some research involving these methodologies. I think for a number of reasons, because it's a standardized and a commonly used method of looking at blood vessels, and I think if we're going to be doing research on a vascular system, in some ways we shouldn't be reinventing the wheel. We should be using common approaches to studying vasculature so that there's a standard that's maintained in a sense.
Is this being used at all right now in this?
I think intermittently there are sites that are using it. I think as time goes on, more and more it will probably be used in more significant numbers. I think that'll serve as a very useful tool for validating some of the MRI data that we're looking at. We can say, you know, this is what the MRI is saying. and this is what the IVUS is saying, and there's the correlation, and that will further substantiate whether or not the MRI data, the flow data, is valid, which will be great because then we can say, we know for a fact that when we do this MRI, it's giving us a really good picture of what's actually going on inside the body before we ever have to go in. Okay? As a segue, I think the IVUS may also prove to be a very useful tool in evaluating restenosis. Restenosis is the idea that a stenosis or a narrowing comes back over time. And I like to tell patients that really, when you go in to do this procedure, you have to accept the fact that at some point in time you will restenose. None of these angioplasties are forever. The question is, when will you restenose? And I think in the future this will be as it is with any other part of the body. The arterial system, the heart. There's tens, if not hundreds of millions of dollars that go into research how to slow down or prevent restenosis. It's really the major focus of a lot of the arterial work we do in the legs, and as such, it'll probably also be a significant issue in the neck and in CCSVI. So, you will restenose. I think it's important that patients look to get treated very well to try and decrease the probability of a short-term restenosis.
There's also a number of other effects that are happening in the tissue, such as inflammation and
Yes.
things that are going to make it the body more prone to restenose, I would imagine.
I would agree.
So perhaps in order to study this, we need to sometimes look outside of our own area of interest. And there is work by other investigators that demonstrates that if you disrupt the vasculature, you will have an effect, for example, on the vessel wall, and that's perhaps most clearly demonstrated in atherosclerosis, where I'm sure you'll also have to put in stents in those cases to deal with very tight stenosis of the carotid artery.
Right.
So that theory has been developing for 20 years, and it's known that the flow rates and the shear stresses against the wall all affect the response of the wall. In the last 10 years, this has also been demonstrated to some degree on some of the venous systems, and there's some very interesting animal work by John Bergen in this direction, and this concept perhaps of marrying our vascular interest with immunological research to do what I like to refer to as sort of a future direction of vascular immunology will be important. But I'd kind of like to turn the tide around a little bit toward you here, and
Thought I was getting away with that.
do that first by kind of linking everything we've talked about. I think it's very critical that we have a means, and that the neurologists be involved in this as well, of monitoring the patient's status, whether it's cognitive status or motor status,
Right.
by using methods such as EDSS scores or MSIS-29 scores or other neuropsychological means and motor means to determine the state that you're in at the moment, so we can follow people over time and see are they getting better or not. That's got to be part of the next level of research as well. And with all of these thousands of people who've been done, that data isn't available, which is a shame. Now there are some groups like David Hubbard, who's got a national protocol where he wants people to begin contributing to such a database. There's already a European database. I know that in Canada they're interested in creating such a database as well. I think it behooves us to get as many interventional sites involved as this is possible. Maybe they can't all be involved because that's going to require a lot of work. But Joseph, I think this was something you had expressed an interest in from your perspective to get involved in that level. And the reason I raise that relative to you is that if you've been seeing a physical therapist for years, and they have years of records to demonstrate what your status was, your ability to squeeze a ball, your ability to walk, all of these quantitative things that they actually do keep records of. And then you've had this treatment, and you go back to your physical therapist, and now you're able to walk at a better gait, you have to put more pressure on this, which can be measured. All of these things would become actually important scientific information, because now it would demonstrate whether or not you really had improved in a variety of ways that aren't so subjective to saying, I feel better. And I think that's a really important part of what we need to be looking at internationally at the moment. And Joseph, I hope that's something that you're interested in too.
Yeah, absolutely. I think we would love to show some long-term data that shows that patients, we can say, these are your symptoms beforehand, and try and quantify that somehow. These are your symptoms immediately after the treatment, 6 months later, a year later, and really start to perhaps try and correlate some of those symptoms with what we're doing as well. And I think along those lines, I think ours and other practices, we're very interested in formulating questionnaires for our patients that really try and extract some of that data to help us correlate it with the treatment and track it over time as a response. And also, quite frankly, correlate some of that really useful clinical data with the imaging data. Because in an ideal world, we'd be able to look at an image and say, yeah, you have these 15, 20 signs that really tell us that if we do this thing has a very high likelihood of helping you in this manner. Right. But until we get this clinical data married with the imaging data, married with the treatment data, it's not going to happen. And so, I think it's important that we try and move in that direction.
So what should people do that have that data now? So say I'm a patient, I've been seeing a physiotherapist for years now, I've got that data, I've had the treatment in wherever I've gone, and I want to be able to contribute some way into the collection of this data to be part of the research. What do I do?
Mark?
Well, practically speaking, if we're going to use it from a research point of view, we need to go through a research process. We have to get what's called an IRB, which is an Institutional Review Board approval.
Right.
In Canada, I think it's called an REB. And we have to obey a lot of HIPAA rules, so we have to be careful that that data goes into a database that is basically de-identified. So, a patient can give all their information. They're given basically an identification number from which they can give the physical therapy data, the angio data during the process itself, the imaging data maybe at different time points, and that data then gets put on a database, and it might be called, CCSVI Canada-1, which would be the first volunteer who puts it there. And the more that data becomes available, the more it becomes possible to data mine it, to draw conclusions from it. The more sites that get involved in supporting this, the better. The more neurologists that get involved in supporting this, the better. And if we begin to do this now, recognizing that thousands of patients are being done, then there's the potential to accomplish, perhaps, I'm not exaggerating, I believe, in 1 year what it currently takes about 10 years to do with federal funding. Because in this way, it's very expensive to do this research at a hospital and to get federal funding to do it. If people are contributing this from freestanding sites and from other hospitals, this reduces the cost dramatically to save that data, to evaluate that data, and since it's being done anyways, this becomes data where, in a sense, everyone is contributing to the national benefit of studying this disease. And I think this is a direction we have to go. This is really the 21st century direction of improving medical research and making things more cost-effective and making things more available much faster for the patients than they're being done today.
Excellent.
I agree. On a practical level, I think patients could ask their practitioner, how they're involved in a sense, contributing to the greater good of the cause of, finding the answers of CCSVI, what their involvement in research is, how they integrate the idea of finding the answers to the ideas of causality and causation in their practice, as opposed to just performing the practice for the sake of performing the practice. I think that's a really important part of doing this, because otherwise, what is our purpose? We're making people better, and that's a laudable and a very valid purpose. But I think at the same time, it's tantamount that as we're making people better, we're finding the reasons to justify why we're making people better.
Okay, there's lots of people looking for that. One thing I wanted to address before we move on, too, is the issue of stents. Because I know that's a hot topic.
Absolutely.
And I think you could probably give us some insight into stenting. Yeah.
Yes, it's obviously a problem. There's been a number of patients that have been in the media recently that have had problems with stents. And what I tell patients first and foremost is that stents aren't evil. You shouldn't necessarily say, I absolutely don't want a stent. Although that is your right as a patient. Every patient has the right to tell their practitioner, this is my body, do not put a stent in my body.
Right.
And, we, in our practice, we have patients who approach us in that manner, and, we will move heaven and earth to get a good result without a stent. But having said that, stents are not bad. They were created for a reason, and they're used all the time for a very good reason. Stents were not created for arteries. There's not artery-specific stents and necessarily vein-specific stents. There are some stents that are used much more often in arteries, cardiac stents, for instance. In my practice, in our practice in California, we place thousands of stents in veins a year, outside of CCSVI.
Right.
These are the same stents that we put in arteries. Okay, we do these in dialysis interventions, cancer interventions, many other medical conditions. Stents do have a place in treating the venous system. It's done every day, thousands of times per day throughout the world, the United States and Canada. Now, having said that, I think it's very important that patients have a frank and earnest discussion about the use of stents in the practice where they're getting treated. When they use stents, how often they use stents, where they would typically place them, why would they place them there? Has there been problems with stents? What can be done after a stent has a problem? And the patient should sit down and have this frank discussion with the practitioner to get a level of comfort that if there is a stent that's going to be used, why would it be used in me and where would it be used in me?
Right.
And what would be the efforts that would be done to make sure that I get a good result without having to have a stent put in me? I would also want to know what experience this practitioner has with using stents in the venous system outside of CCSVI. It may seem simple to just put a stent in a vessel.
Right.
Again, I could probably train a monkey to do it, quite frankly. But in all honesty, it's, you want someone who's done something thousands of times,
Right.
so that they understand the subtleties of when it's appropriate and when it's not appropriate to do it.
Joseph, let me ask a question here. I was in Glasgow a few weeks ago and heard a number of other interventional people speak, such as Ivo Petrov, for example, Marian Simka. And in the early stages, it seems like when I hear these different people speak, they all do this a little bit differently. And so there are some people who have used smaller size ballooning, for example, not necessarily stents. There is Marian Simka's group in their paper recently published by Ludiga as the first author, I think, in Phlebology, where they comment on their first 300 cases in terms of the safety, and they comment for the most part that it is a safe procedure, as you mentioned earlier, that there are some complications associated with this. They all have slightly different methods of doing this, and the concern raised at some of the last meetings has been, what size of the balloon should be used. Is 8 millimeters enough? Is 10 or 12 enough? Do you have to go higher than this? And how do you determine that? And then the same would be true for the stents, depending on where you're putting these stents. Since the veins are so pliable, one has to worry that if you return blood flow to the system, will the size of that vein now change? I think this is, to me, it's an important question that, at the moment at least, there is no consensus by the interventional radiologists what to do here. And we, in the summer, we formed this new society called the International Society for Neurovascular Disease. One of the hopes is we could bring together people like yourself to write a white paper on this and at least present some, as you said, consensus on what's the minimally best way to do this. Because I'm wondering if some of the reasons of the problems we've been seeing in the last 6 months of people coming back to get rescanned or retreated is because maybe they were done suboptimally. And how do we get to that level, Joseph?
I think you raise a really good point, Mark. In our practice, we see perhaps 4, 5, 6 patients a week who are returning after previous treatment with a malplaced stent, a stent that's too small, oftentimes resulting in thrombosis. And this, of course, leads us to desire this idea of having a more global and uniform standard for the placement of stents in some broad stroke at least. And this isn't without precedent. For instance, the Society of Interventional Radiology issues white papers, as do other societies, as to a minimum standard and general guidelines for complications and the way that different diseases are treated. I think it would be very appropriate and very important in doing this to make sure that, that the application of stents and just the application of angioplasty even for patients in terms of, as you mentioned, Mark, balloon sizes, locations, the veins that are looked at, standard criteria for saying, this is a good result, or this is not a good result, or this is something that needs to be treated, or, let's talk about anticoagulation. A lot of these different variables that go into the treatment of CCSVI patients today, we could establish a more uniform standard so that practitioners throughout the world, number one, would hopefully help achieve a better result with fewer patients that come to practices like mine with an unacceptable result from a prior treatment, and perhaps to move this body of knowledge forward with a more uniform front so that we can get better acceptance of the practice and perhaps better data that, again, helps us find those causalities that really make a difference in the treatment.
And that's important for the research studies that we've talked about, because if two people treat somebody differently, it becomes hard to unwrap why one person gets better and the other person doesn't. So having that standard where there's at least a minimal agreement on how to do this makes it easier to draw interpretations from this, easier to analyze that data. So I think that all kind of goes hand in hand at this point. So we never did quite get back to you. So from a general point of view, I got an email today, and I get all sorts of emails from patients. And I have to tell you, this was a gentleman who said his wife had been treated, and I'm reading this, and it sounds a lot like your current experience. In fact, I almost wondered if you'd sent it to me. And apparently he was describing a situation where when they were on their way to get treated, they had to get out of the airport, and they had to take an escalator, and his wife was quite afraid to walk up to the escalator because of balance issues, and eventually got on it with some difficulty. And at the end of this, by the time they had gone home, she had felt that her balance had returned, and she was much more stable and really able to even just navigate something like an escalator more easily. For us to really determine what a major effect is in this type of change in your life, it would seem to me something as simple as recovery of motion of your hand or recovery of balance, even if you still had to use a cane, for example, but your balance was better. How important is that to you as a patient, and how big a change is something that small to you in terms of how it affects your life?
Huge. And I think my biggest awareness before or after I came back was how I hadn't realized how I had adapted before I went down. So the response to the treatment was even greater than I had expected. And I think for quote-unquote normal people, or people who have not lived with multiple sclerosis, the smallest change can be huge. We were in the place where we had treatment, and there were people there who it was a difference between being able to transfer themselves out of a wheelchair by themselves, thereby alleviating that burden from their spouse. That might not be huge to somebody who takes for granted that they can just stand up from a chair, but that significantly changed the lives of those people. So for me, having my balance back means that I'm using a whole lot less energy to do the things I want to do, and I can focus on learning how to walk again, which is very significant, because when you're just constantly compensating for that lack of balance, you're not really using your muscles in the way they were intended to be used.
So given that some people with MS have had this for a long time,
Mm-hmm.
you know, even if you have this ability to recover, and returning blood flow, for example, to the nerves might make certain functions better. That might explain why some people who couldn't really move well before or not at all can now, after this treatment, begin to move their hands or move
Right.
their legs. Blood flow may affect some, I think you were referring to this as the autonomic system. There's certain components of this that may improve because of improved blood flow. Clearly, if you don't have these inflamed lesions in the brain, that could affect other issues that relate to both motor and cognitive function as well. I think it's important for patients to realize that these things also may take time. It's taken years to get to the point where they are, and you may go home after this operation. And I remember a Canadian person telling me who'd been down to California to get treated, going home and being rather disappointed that at first they actually felt worse. They didn't feel better. And over time, they actually got a little better and a little better. And at this stage, they are much better than they were before. And I think this type of response seems to be very different from person to person. So again, I think it's important to recognize that this is so new. We don't know that that same person with the same stenosis and truncular venous malformation might take months to improve, might not improve, or might get improved in some cases, you know, within days from having had this treatment.
And I think managing expectations to that point is absolutely critical.
Absolutely.
You know, to think you're going to go down there and all of a sudden, in my case, after 26 years, I'm going to be doing cartwheels out of the place is not a reasonable expectation. And in fact, having a follow-up plan and a physiotherapy plan or an, you know, I've got muscles that haven't been used for probably 20 years. So I need to work with, you know, my brain's capacity to refire those neurons.
Sure.
And rebuild those muscles, and that takes time. And I think one of the messages that I've received from the people that are helping me in that perspective is slow down and let it happen, because it's not going to happen overnight. So in fact, some of the people I work with are saying, Terry, realistically, we're looking at a year or a year and a half, maybe longer, to rebuild those muscles that haven't been used for so long.
So I would like to perhaps close this discussion by saying that, you know, we're at an early learning phase still,
Yes.
that clearly there have been some benefits for some subgroup of the MS population, that there's a lot to learn, and perhaps more exciting is that there's a lot of important clinical translational research to do here, and that there is potential to address these questions. We have the technology to deal with everything from studying blood flow and perfusion to the brain to the simple anatomical information and blood flow information in the head and neck. And all of these things are new tools we have today that they didn't have back in 1935 when Tracy Putnam actually was convinced that a lot of the MS plaques were created by obstructed venous flow. He didn't have an MR scanner then. Today we have the fantastic technologies of stents and balloons and angioplasty and all the different imaging modalities. And so we are poised to be able to address this question now in the 21st century.
Excellent. On that note, I thank you gentlemen both for taking the time out of your exquisitely busy schedules. Much appreciated. And thank you.
Thanks.
Another thing that happened right away, sorry, Gabby, was you that asked, was I got up to go to the washroom for the first time and I could feel the tiles under my feet. Sorry, I can't.
You mean feel the tiles? You mean,
it was like,
you mean your
wow.
feet had no sensation
I had,
before, or?
apparently not.
Huh.
Yeah, I felt the tiles, I felt the grout in between the
Do you ever have
tiles.
those times when you get up and you've had the legs crossed too long and it's numb?
Yeah.
She's got both numb from, I mean, if it progresses worse and worse, but from knee down, it's virtually numb.
Yeah.
And is that true now?
No.
No.
But
Yeah.
the feeling comes back not completely. It's broken
there's
up like the
patches.
ice breaks up, right? So there's,
Yeah.
so day 3 she was doing this and said, what are you doing? She goes, I'm feeling the sheets.
Because I could feel the
Things that-
texture to the sheet, and it felt exaggerated almost, because I hadn't felt it. It felt
Right.
like graham cracker crumbs or something on the,
When they-
but it was a perfectly,
When they wheeled her back in the room, of course I see her and first thing I said is, how do you feel? And she goes, I feel great. Of course, she's still sedated. She was no pain.
What's she going to be like when she's not sedated?
And I said, well, you have to stay, for 6 hours they have you flat. I said, do you want to finish watching the movie we started because we were killing some time beforehand? She goes, yeah, that'd be good. She got settled in. She goes, get the covers off my feet, and her feet were just hot, which is just unbelievable.
That's great. Yeah.
And then about 15 minutes later, she was out for 12 hours.
Wow.
And which was great. That's the first time you'd slept for 12 hours
Oh,
in 20 years.
Yeah, well, yeah, no kidding. Yeah, sleep is a big thing.
How long it has been since your angioplasty?
Almost 3 months.
October
So the 28th of October is the date.
And do you have a progressive improvement?
Yeah, well, I was telling Mark and Joseph yesterday, I think I was, that the other day I was at my therapist, my physiotherapist, and she does the neuroelectrical muscle stimulation, where they put the pads on and they slowly crank up the juice. And I was able to feel it fairly quickly, and so I said to her, what number are we at? What number did we hit? Because I feel it. And she said 8. And I said, what are we usually at when I feel that? She said 34. So, and that is new, because we've done the neuroelectrical stim, but it hasn't been, it sort of has been progressively going down from 34 to now we're at 8. So.
Now everybody thinks that the road to recovery is a flat line that goes like this, and it looks more like the stock market.
Yeah.
So, you get a good day and then you kind of get a bad day. And it's difficult to manage the expectations and the emotions around it, saying, well, I can walk yesterday and today I'm dragging this leg again. What's going on?
And to that point, I've noticed some of the inflammatory processes that used to set me back and my patients back. For example, acute viral infection. Actually, I had a very big and long massage too, which just liberated a bunch of stuff into my lymphatics, and that wiped me out too, very inflammatory. Same sort of setbacks.
Now, let me ask you this. This is interesting. So, remember Eleanor Barker? Her brother, Grant Barker, is a paraplegic. And I met him back in Canada, and he's in his wheelchair, and, I'm not being facetious or anything, and he's sitting here like this, and I'm going, hi Grant, how are you? And, tried to shake his hand, because Eleanor wanted me to put contact with him, and that's it, there's just nothing. And they eventually somehow got him down to Gary Siskin in Albany. And we had scanned him here, and he had severe bilateral stenosis, and I don't know if I looked at the atlas at that time, that was very early. And I don't know how they even got him here, because to get him here they had to rent a special van, and it was a huge process for them to do this. Anyways, they got him to Albany, treated him, got him back home, and for the first time in years, and this is not going to sound like a lot, he can move one finger.
That's huge.
He now uses that finger for a specially designed computer mouse that lets his eyes contact with the computer screen. And Eleanor just wrote me a long thing about, well, it's not a lot, but he's now talking to us again. He's joking again. He talked with one of his sisters on the phone for the first time in years, and he'll probably never get out of that bed.
But his quality of life.
But he has the ability to talk to people again instead of just sitting there with a big smile
I
on his
think on
face.
some level what a lot of people, maybe myself included, may not realize about this whole thing is, what defines being a human being. And in a lot of ways, it's the ability to have some degree of control over our lives. And in some ways, the ability to interact with other human beings on some level. And even if, like this fellow you just talked about, he's regained the ability to have some degree of control in his life. And he's gained the ability to interact with other human beings in a meaningful manner.
For his family, it's a wonderful thing. But the reason I remembered him was her comment about inflammation. Apparently, he had constant bowel infections. And apparently now, since that treatment, he's had only one infection. And so it kind of links a little bit to what Terry was talking about there, that even these bouts of getting sick are less. Maybe your immune system is strengthened up a little bit, and you're just healthier than you were before.
Yeah. When I hear things about bowel and bladder function, which are autonomic nervous functions. We do see patients who have increased numbers of urinary tract infections, and that's often due to just, if you have urine that's static in your bladder for a long period of time, it's more likely to get infected.
How about people who claim that after the treatment they recover their continence? Because many MS patients are incontinent.
Right.
Now they recover this. They're able to control
It's
themselves.
an autonomic nervous function, and in our practice, and what I'm going to say, of course, is conjecture. There's no science behind this, but we do find that patients who present to us with fatigue, symptoms of fatigue, symptoms of headache, sometimes headaches that will wake you from sleep, and also difficulty sleeping. These are the patients who seem to do particularly well. Okay? And those symptoms seem to appear to resolve quite often if they do have them. Now, in conjunction with those three symptoms, patients who do have those three symptoms and who show an improvement seem to show more improvement in other problems as well. For instance, the autonomic nervous dysfunctions, thermal regulation, cold hands, cold feet, bowel and bladder function. People who have these three symptoms seem to improve with the autonomic dysfunctions more often and better. We also find that patients who have these three symptoms, and these symptoms, but in particular the first three that I talked about, tend to show a more likely improvement of other things such as their balance and their motor dysfunction and other abnormalities. Of course, a lot of this, if you were to form a scatter diagram of improvements and the treatment, it's all over the map, but there do seem to appear some very general trends, which will be interesting to try and squeeze out of the data as we do more and more clinical investigation of the patients before and after treatment.
Is the percent of stenosis for this particular category of patient that you described less? The percent of stenosis for this
I think, Gabby, it's too early to answer questions like that. On the one hand, I could say, I like to classify there's early occlusion and there's true restenosis. Early occlusion are the patients who were treated perhaps several weeks to a month ago, and they thrombose out their jugular. And of course, some of these patients their disease was of a degree that it was going to happen no matter what we did. The best efforts do not yield a good result. A significant number of those patients, however, who have early thrombosis, early occlusion in a sense, I believe may be to suboptimal technique in performing the treatment. You should separate that from restenosis. Restenosis are the people who've had a good technique, who've had an angioplasty or a stent, and gradually over time that comes back. And as to the rate of restenosis, what causes it, how to prevent it, how it compares to other venous vascular or arterial vascular systems, I think it's just much too early in the disease and the study of the disease to be able to answer those questions. Then we look at the azygos vein, and there's all sorts of pathology there, which really is reinforced in our practice, the importance of looking at it and treating it when appropriate and how appropriate.
And in the event of restenosis, repeating the procedure, is that something that can be done? Is that something that can be done 3 or 4 times if it needs to be, or?
The analogy I think of for answering these questions is patients who have fistulas or grafts in their arm for dialysis access. These are venous constructs that are prone to stenosis. And essentially the paradigm has become that if we want to preserve this integrity of this venous construct, it requires intermittent angioplasty. Okay. Now, granted, these are venous constructs that are exposed to arterial level pressures, very high level pressures, and the body's response to that is the form of stenosis. So the degree and the frequency of angioplasty is going to be much greater. But to answer your question perhaps more directly, Terry, instead of beating around the bush, yes, of course, something that's been angioplasty can be angioplasty again. If perhaps in an ideal world we have patients who we find that there's a really good response to the angioplasty, right? So that we know we're doing the patient some good and we're not bringing them back for no good reason. And we put them under some sort of imaging surveillance, whether it be MR and or Doppler angiography, perhaps once a year. and we monitor the diameter and the flow in these vessels, such that once it gets to a certain point, before it perhaps even becomes clinically symptomatic, we can go back in and get those vessels up to a point. You know, if you subscribe to the belief, and I think we can all subscribe to the belief, that MS is by and large a progressive disease, right? I believe that it would be better to try and prevent those areas of restenosis that cause a progression of the progressive disease before they happen. And so it'd be nice to have this imaging follow-up so we can get in there and preserve the healthy venous flow, decrease the abnormal venous hypertension in the intracranial venous vasculature in order to prevent whatever progression of the disease there might be. And what that is, you know, we don't know yet, but this is really why we're sitting here talking today, isn't it?
Exactly. At the same time, you want to be able to maintain the quality of life of the person with MS too. You don't want to
Absolutely.
have that sort of nerve-wracking relapse now.
Like you know, we were just talking about a moment ago, you know, you have a good month and then you have a bad day, and it's very frustrating and very probably unnerving to you.
Absolutely.
And I would think that as an MS patient, that knowing where you could go back to, you would probably want to do, within reason, whatever you could to go back to that place.
Or even if CCSVI is not a cause of MS, if it's something that can exacerbate that problem, then we want to keep that part of our body healthy enough so that we maintain that window of operability.
I agree. I arrived at this idea. As an engineer, I really kind of think of the brain as a very complicated piece of electronics. Obviously, Mark's electronics are much more developed than mine are. But, you know, when you have a piece of electronics, for instance, that goes in your car, it's intended to operate from, you know, X degrees Celsius to X degrees Celsius. And you fall outside of that, and that's when the function of this device breaks down. And in some sense, in a very simple fashion, I see the brain as that way as well. You know, the neurons of the brain are going to have this window of operability that function very well in this window. And there's, you know, we don't know what these factors that may shift the function of that brain outside of that window of operability. But like Mark said, if we are finding things and we can find a causality that shift that function back into this window of operability, let's try and maintain that function within the window of operability by doing whatever we did to get it there. And try and, while we're doing that, figure out why that happens.
Exactly.
Great.
Exactly.
Question from the crowd, then. I don't know if you answered this differently, but how is it that right after a procedure, we're able to see some patients have these miraculous recoveries? Zero pain, the balance is restored within a day or two. I mean, neurologically, wouldn't you expect that this would take a long time to recover and repair itself? So the immediate results, is there an explanation or theory behind that?
In my mind, it does sort of go back to this idea of a window of operability. You have the brain function and its window, and you know, due to perhaps the abnormal venous pressures or these factors that we don't completely understand, this brain function has fallen outside of this window of ideal brain operability, and you have the chronic fatigue and the brain fog and some of these other problems. And if we change these factors that shift that window, the brain function back into that window of operability, all of a sudden you can fall into this area where most of us would consider, you know, this is how it feels to be normal again, as opposed to just slightly outside of normal. It gives me hope in a sense that patients who have fallen outside of that window of operability for decades perhaps shows us that the brain perhaps and the neurologic function is very robust. It can live outside of that window of operability for a prolonged period of time. But it does speak to the lability of that function, that these combination of factors, whatever they may be, can shift in and out of that window of operability in a minute's notice.
And I think your example before, you know, when your leg falls asleep, okay, you've lost your feeling, right? You know, you maybe, I'm not sure if the cause of that is a vascular reason or not, but I think one of your concerns was, is, you know, the tissue able to handle 5 minutes without oxygen or 5 years with reduced oxygen levels? It's known in at least animal diabetic studies that, and in diabetes, remember, we have reduced blood supply, we have microvascular disease, that there is a problem with nerve conduction velocity. But if you increase the blood flow to the nerves, which have also suffered from lack of blood supply, the nerve conduction velocity increases again back towards normal, and it increases almost linearly with the amount of increased blood flow you give it. And so that may suggest that certain functions, such as the ability for say, Steve Garvey to be able to move his hand again so quickly, could be that that tissue becomes latent as long as there's enough blood supply there that the tissue hasn't died.
Right.
And so it is rather amazing that some people can go for as long as they have with reduced blood supply, and that tissue has survived. And I don't think we know the answer to that as to which tissues will survive and which won't.
Right.
But it is still pretty amazing that you return that blood supply. You get your leg back going again, and you're up and walking after that sleep attack has gone away. And I think that's what's happening in some of these people. We're seeing that type of phenomenon.
In a sense, it's almost like a hibernating neuron. Such as we have hibernating myocardium, perhaps we have hibernating brain.
Well, all the wonderful work that's been done in the area of neuroplasticity, too, it can tie into that as well.
What other diseases can we start to look into besides MS that are obviously going to have some profound impact?
Well, now I don't know if you want this videotaped or not.
Right.
We have two
I'd
very
like to plead the
interesting
fifth on this.
cases, and I think you'll be interested in one of them. I think the first MS case that we did was actually a patient that had idiopathic intracranial hypertension, and that's where it's clear that there's an increase in hypertension in the brain. And these people, I think, end up getting CSF drained to help alleviate that pressure. And this is a standard process to doing that. So for whatever reason, that patient got sent to us, and we scanned them. And you look at we did the CCSVI protocol, and you look at the veins look just fine. But you look at the blood flow, and one vein has no blood flow in it. I mean, it's really amazing that it actually looks normal anatomically, no blood flow. And this is really amazing because it's well known that for this intracranial hypertension, that there are, according to one paper, 90% of these people have stenosis of the sigmoid sinus or the transverse sinus. And then those can be dealt with stents or other means of dealing with them. But here is kind of the first hybrid case. It's kind of like, studying the Australopithecus for mankind. It's this connection, this historical connection between idiopathic intracranial hypertension here, CCSVI here in sort of the neck, and by heavens, this one person is the first case, and we haven't written this up yet, but is the first person who actually has CCSVI-like symptoms, but he's the intracranial hypertension case. And then we have one other interesting example, which is somebody who had Parkinson's, and we've now reviewed their data, and lo and behold, it looks just like some of the cases we see coming from your place, who are MS cases. And we go through this, we do all of the vascular evaluations, and I would have told you it's probably MS. We then go and look, and lo and behold, this person has lesions just like an MS patient. So it makes one ask the question, if that's just a random Parkinson's case that we've reviewed, and they have all these symptoms of MS, what does that tell you about other neurological interpretations? I think it means that we need to be doing a lot more imaging for these people, and in a complete analysis, it could be that some of these people have been miscategorized, for example. So there's still a tremendous amount to learn about this.
Oh, I've never been medicated. And that was a choice I made. I've never been convinced by the data that they were effective therapies.
Yeah,
So-
I was curious if you
Yeah.
did.
No, they never made sense to me.
Exactly.
So, and that's my personal thing. I have lots of patients who choose to take them, and I don't judge their decision.
Did any of them have CCSVI?
Yeah. In fact, there's a lot of people who have chosen just to go off the drugs. I think that's great because I think the level of toxicity that those drugs bring just brings additional problems. I rarely hear someone say, "I feel great on these drugs. These drugs changed my life."
you know. And like I said, I don't judge, I just observe. Well, it's basically chemotherapy, you know, it's just,
With side effects, sledgehammer.
with lots of side effects. And you know what? What are the long-term outcomes of having people on medications or therapies that are that toxic for the long run, you know? When I was diagnosed with MS, I had a fabulous neurologist. He's now the head of MS research at Oxford in England. And he said, you know what, I can't really put you on. There was only one drug at that time. He said, I can't really put you on it until I've observed what's going on with you for 2 years. And then it's not a long-term solution. And what I hear out of the neurology community is very conflicting. Some of them say, oh, you've got to be on it right now. You've got to start right now, and you can be on it for the rest of your life. And I have other neurologists who say, you know what, this is a toxic group. So this is our trump card. We don't want to have to play this card until we absolutely have to. So, you know, there's conflicting messages coming out of the neurological world too. So when I was at my absolute worst, I was driving an hour to work every day. And I had 3 or 4 pit stops in that 1 hour. So my bladder would last about 15 minutes. And there was no negotiating. It was like, even if I was close to a pit stop and I really didn't feel the urge, I would stop anyway, because I wouldn't necessarily make it to the next one.
So now we get into the habits the accommodations that your brain calculates for, which is one. So you form the habit, okay, before I leave I have to go to the washroom, even if you don't.
Yeah,
the other one is, if you or I were to stumble on something, our normal reaction is we put our foot out and we stop the fall. With Terry, her brain has been programmed that there's no way that this leg is going to get out that far.
Right.
So her brain says, okay, let's minimize the impact. So as she goes to trip, the next thought that comes in is I'm gonna go down, I'm gonna roll onto my side, and I'm gonna try to minimize the impact. So she has to actually deprogram that.
Yeah. There's a lot of retraining that the brain has to do.
I now have the strength that I can start to
try
to prevent the fall rather than accommodate the fall.
There's a lot of work to be done.
Lots of work. Yeah.
But she doesn't have a smile.
I do absolutely with a smile. You know, Gabby, this, and I'm tired today because I was walking around the hospital all day yesterday. This is new, as opposed to, you know, 2 years ago when I met you, it probably would have been this, or a year ago, or it would have been this, or something very discreet. I always have a hand on something, you know. But
people who haven't seen her in a while say,
to do this, bend over and pick something that was impossible.
How's the MS, thing going, the progression? She goes, watch. And then she does this, and she bends over. And
here, let me do it.
There you go. And people don't get it. So this is
huge for me, because previously, if that was laying on the floor, I would be like, oh.
Well, you would have sat first.
Well, and it became a strategy of how do I retrieve that.
How do you get down?
So if this chair was here, that's easy, right? But if that chair wasn't there, it would have been this.
Get down.
To pick it up, and then it would have been an arduous get back up again, where now I can just go like this.
Things we take for granted.
And like I said, I'm tired right now, so this is actually very good.
So what type of MS were you diagnosed?
I was diagnosed with relapsing remitting.
And when was the last time you had a flare of symptoms?
Well, I had my first relapse, the relapse that had me diagnosed. And then I had 10 good years, maybe with 1 or 2 relapses that were really self-inflicted, because I had a lot of fun in my younger years, and I didn't really pay good regard to, healthy lifestyle. And then I would say, well, just before we met, so I skied the last time just before we met, so that was about 17 years ago. And
so back to my analogy of the stock market, even though it's relapsive remissive over a long period of time, you're going to watch this progress.
Yeah, so it becomes secondary progressive. Yeah. And now it's going to be reverse progressive this way. So yeah, I'm very optimistic. And I mean, I've done a lot of work and research into sort of neuroplasticity, psychoneuroimmunology, and mind-body medicine. And in that, there is lots of good hope for
refiring neurons.
Terry will say, I'm going to go to my car and get my purse. Do you know why? And I'll say, why don't you go? Because I can.
Because before I would go, hi, I forgot my purse in my car. Can you run out and grab it? And yeah, so it's
So as your weight goes down, Mike's is going to be going up.
yeah, that's right. That's right.
How much chance of that?
Yeah, but yeah, lots of good stuff. And I often, my biggest problem is that I don't pay enough attention to myself as a patient because I am focused on everybody else. So when I actually sit down and think, oh, cool, this is me now. You know, it's my turn. It's really cool.
On the highs and lows emotionally, because there's huge. I mean, even before the procedure, someone would say, I understand you're going to go down the procedure. She'd start crying. It was just so emotional knowing that she was going. And part of it, as we kind of talked through, was she's had MS for longer than she hasn't. So
It's the devil I know, right?
What does life look like if you don't have MS? Who are you? She's become the MS, naturopath. Everybody turns to her because of her management of the disease and the lifestyle and all the rest. So it's like, oh my God,
So now
am
I
I
needed
really
to
going
become
for this?
the naturopath who had MS.
Yeah, exactly. But she would come home and she'd be like this.
Oh God.
And it would be, what's wrong? Well, I'm out of energy and my legs aren't working as well. And I said, so let's back up. What did you do today? Well, I went to Winners and I did this and I picked up that from the grocery store and then I went over here and dropped off that. I had to go mail these things. You did all these, you did 10 things that you would never have been able to do before, and now you're wondering why you're low on energy.
We did, without exaggeration, which he's doing a little bit of, we had one day where I had a staff meeting at my clinic.
Good.
I did a grocery shop before. We went and had a staff meeting, cleaned up after the staff meeting. Then we went shopping at Costco, and then I went clothing shopping at a local store. So that was 5 things that I did in one day. Previously, I would consider maybe one of those in a week, and I would have to really psych myself up because it would be that exhausting, that debilitating. Yeah. And like I said, I didn't realize until after I'd had the treatment how bad my fatigue was. I didn't realize, because it was like a gradual thing, right?
So now you had the scan, but not because you had any symptoms, just because you want to do a follow-up.
That's right. Yeah. So Thursday night, I came home, and Mike said, you going to help me cook dinner? I said, no. I'm going to sit right here on the sofa and read a magazine. And I thought, well, hold on a second. I'm sitting here reading a magazine. Whereas typically on a Thursday, I would have close to crawled in the house and just melted into the closest chair, sofa, whatever. And I would have slipped into a coma until Mike fed me.
If you drive yourself home, I see the lights, come out,
Yeah,
go get her
he would
from the
escort
car,
me from the
help
car,
her.
yeah, by the end of a full working week.
Yeah.
I'm wondering.
That was just kind of normal, so I didn't think about it. And then it was that night that I thought, holy crap, not only am I not exhausted, but you know what? I'm here choosing to read a magazine, choosing not, like I'm making choices, I'm thinking clearly, like there was a lot, so that,
Great. Fantastic.
Now, where is the tiredness coming from? There's one thing that strikes me that if your muscles are tired,
yeah,
it's because you don't have enough oxygen.
here's how I
And,
describe it.
and I'm sorry, I was kind of asking a general question, and maybe Terry, you and Joseph can speak to it. So, doesn't it make sense that fatigue may be directly related to cardiovascular power? If it's an issue of oxygen saturation?
You know what? That would make sense to me because how I describe it, what it feels like, and what I hear other people describe that I can relate to, is that it is a deep cellular fatigue. You feel it at the cellular level. It's not in the muscles or it's not in the head. It's in every cell and every tissue in your body, which would support the oxygenation issue.
In my mind, I sort of think, you feel chronic fatigue and tired, and maybe in some manner that's like falling asleep at night. As you know, in order to fall asleep, both of the reticular activating systems on both hemispheres have to shut down. That's why we fall asleep. And I'm a simple guy. I just sort of think perhaps really what it is, again, it's just poor oxygenation falling outside of this window of operability where your reticular activating systems are just not functioning properly, and your body says, okay, I'm fatigued, I'm tired, I'm in sort of a semi-sleep state.
Well, maybe it's the brain, the autonomic system, possibly telling you, or
Well, I mean,
I'm tired.
And besides, if it was a muscular problem, why does it turn around like that? I mean, it's not, you know, what's turning around like that? The only thing that's really turning around like that after we do the treatment is oxygenation and decreased pressure.
Now,